Assalamu alaikum. My name is Dr. Hafiz Amjad representing Medical Unit 4. Today lecture is about pneumothorax. And sorry I couldn't deliver my lecture on previous week, that was on mitral stenosis. Well, probably that was given by Medical Unit 2. Today is going to be first lecture for you people. Very important topic of pneumothorax. Especially in emergency, many patients, they are misdiagnosed. They actually are of pneumothorax. So that's why please keep in mind the importance of this topic. So defined as air in pleural space. Simple definitions. It shouldn't present normally, and due to any reason, if in pleural space you find air, that will be called as pneumothorax. Next classification is spontaneous and traumatic. Traumatic you will study in surgery, and spontaneous is our topic of today, that is of primary and secondary. Primary. In primary spontaneous pneumothorax, patient will be young, otherwise healthy, tall and thin. Majority they are male, having some genetic predisposition, and if smoking, there is an additional risk factor or predisposing factor. Recurrence is very common in primary spontaneous pneumothorax. Primary means, as in other diseases, there is no underlying cause. This is believed to be due to rupture of apical subpleural bleb or bulla. Otherwise, there will be previous X-ray chest will be normal, and there will be no history of any other disease. So the next one is secondary spontaneous pneumothorax. If you find any underlying pathology who involves lung, that will be caused as secondary pneumothorax. The most common causes are chronic obstructive pulmonary disease and tuberculosis, followed by pneumonia, asthma, interstitial lung disease, malignancy, and in some connective tissue disorders as well. So what is traumatic? It is accidental and iatrogenic. I have already told you, because this is a topic for surgeons and you will study in the surgery. Leaving it. This next is catamenial pneumothorax. Just remember definition of this. This is in women of age 30 to 40 years and during menstruations, usually on the right side. Clinical terms: closed pneumothorax. What is closed? If pleural tear is sealed, and obviously pleural cavity pressure, this one, that will be less than atmospheric pressure. So this will be sealed. This one is open pneumothorax. This will be open. Air will be going here and there. So the both will be same. Pressure will be same. This is tension pneumothorax, which is actually a very important emergency, and actually my emphasis for today's lecture is on tension pneumothorax, which is important for your UHS examination point of view as well. So pleural tear act as a ball valve mechanism. It will go inside, increasing the pressure here, pleural cavity pressure, that will be more than atmospheric pressure, because air is going inside, not on other side, as that was in open pneumothorax. So this will be an emergency. The next, same one as I previously. Clinical manifestations, they depends upon whether patient is having underlying pulmonary disease or not, patient speed of pneumothorax, and size of pneumothorax. So what are the common symptoms? Most common symptoms of pneumothorax is shortness of breath or dyspnea, followed by chest pain, dry cough in some patients, and profuse sweating and shock-like symptoms in tension pneumothorax. On examinations, you will see first vitals. The patient will be having tachycardia. Tachypnea means increased respiratory rate. Obviously, as because patient having lung pathology, the respiratory rate will be increased. So hypotension only in patient with tension pneumothorax. If you find low blood pressure in patient with pneumothorax, always suspect tension pneumothorax. Then raised venous pressures, JVP is raised. This will be also in tension pneumothorax. What are findings on examinations? On inspection, you will find tachypnea, increased respiratory rate, and decreased chest movements on that side because lung will not be moving because of increased pressure in the pleural cavity. So the next tip for you is how can you decide on inspection that this patient is having abnormality of any kind on right or left side of the lung is on inspection the side which is moving less is always abnormal, whether is it uh, bulge outside or whether it's going inside. If that side is moving less, that will be a diseased side. Next is on palpation. Trachea will be shifted to opposite side in large pneumothorax and in tension pneumothorax, and vocal fragments will also be decreased. Then the percussion there will be hyper-resonant, and auscultation there will be decreased or absent branch sound. And how can you differentiate between pleural effusion and pneumothorax clinically? Because that patient might have tachycardia and decreased in pleural effusion as well. There will be decreased chest movements on affected sides. Trachea might be shifted, will be shifted to other side, and and there will be decreased vocal fragments as well. Here are the findings is only percussion. If on percussion you find hyperresonant, that is pneumothorax, or if you find percussion node is dull, impaired or stony dull, that will be pleural effusion. The only clinical sign of differentiating between pneumothorax and pleural effusion, because auscultation again breath sounds will be decreased in both pleural effusion and pneumothorax. Cardiovascular examination, patient might have tachycardia, especially in patient with tension pneumothorax because of decreased blood pressure, and other pneumothorax as well because of sympathetic response. And findings in tension pneumothorax, there will be pulsus paradoxus. What is pulsus paradoxus? Normally during inspiration, because of increased venous return and expansion of the lung and expansion of the lung vessels and pooling of blood into the vessels, there will be decreased stroke volume, resulting in decreased blood pressure to less than 10 millimeter systolic during inspiration. This phenomenon will be exaggerated in patient with tension pneumothorax because once there will be a large pneumothorax that will compromise left ventricular filling, there will be decreased stroke volume and decreased blood pressure, especially systolic blood pressure. There will be hypotension because of decreased stroke volume. There will be distended jugular venous pulsations because there will be pressure on right ventricle, as well as there will be increased venous return. Cardiac apical displacement in case of tension pneumothorax because of pushing of cardiac to other sides. So investigations are very simple. You will first go for chest X-ray, ECG to rule out acute coronary syndrome, ABGs, ultrasonography for pleural effusion, and CT chest in small pneumothorax. Chest X-ray. The next I will show you some chest X-rays will resulting in pneumothorax. This is the chest X-ray showing pneumothorax on left side. What is this? Look here. This is lung parenchyma, tongue-like projection, and this whole black one is pneumothorax. Whole side. Absent lung markings. Look at other sides. There are some few small dots and linear shadows. These are actually blood vessels and bronchi and bronchioles. These are called lung markings. These are absent here on the side of pneumothorax, resulting in compression and collapse of left lung. Next, on the right side, look here, this one. This one is whole is pneumothorax. Next, again, this is collapsed lung marking. There is a linear shadow, linear lining. Look, there are lung markings and no lung markings here. Now, this one, tension pneumothorax. Displacement of mediastinum and trachea. There is large pneumothorax. This is actually a small pneumothorax. Actually, I have bilateral pneumothorax. This one, and here, look, there is a catheter already placed, pigtail catheter. So this is small pneumothorax that is inflated after this chest intubation. This is CT chest showing pneumothorax. Look at this X-ray. How will you differentiate patients having pneumothorax or not? This is the real X-ray patient in our ward. Look, there are lung markings on both sides. Both sides. It's a whole black or hyperinflated, giving impression of presence of pneumothorax. But if you see, you will see lung markings everywhere. So this patient is having actually long tubular heart, low-lying flat diaphragms, hyperinflated lungs with some opacities, or tuberculosis, or some other lung pathology. So this is a patient of COPD. There is no pneumothorax in this. Look at this. This is collapsed lung markings. This is whole pneumothorax, and again this is a catheter placed here. If you find pneumothorax, catheter will be here, catheter or chest intubation, and if you find effusion, that will be here. Next one, pneumothorax here, this one. Primary spontaneous pneumothorax. If patient is asymptomatic, observe, because the lung will be normal, both lungs will be normal, and it will result in the absorption of air, resulting in normal chest X-ray, and patient already is asymptomatic, so there is no need of any intervention. The next is, if patient is symptomatic but having less than 15% of lung volume with pneumothorax, go for high flow oxygen and needle aspiration only. Don't go for chest intubation. So if patient is symptomatic but more than 15% of the lung is involved, go for high flow oxygen and aspiration using a pigtail catheter. And if it is recurrent, pleurodesis. Scandi pneumothorax, again high flow oxygen, chest intubation, because that lung is diseased, so it will not absorb the air and patient will be symptomatic and patient may go into tension pneumothorax. So always go for chest intubation with treating as the underlying. Tension pneumothorax, always remember the first intervention is life-saving procedure, that is needle decompression in second intercostal space on front of the chest. Immediate, if you find a patient with tension pneumothorax, go for needle decompression. Then is high. So what are boundaries of safety triangle? There will be on lateral side pectoralis major and on anterior side, lateral border of pectoralis major. On lateral side, lateral border of latissimus dorsi and inferiorly fifth intercostal space and superiorly base of. Indication of chest intubation: unstable pneumothorax, severe dyspnea, large lung collapse, open heart tension pneumothorax, recurrent pneumothorax. What are the complications? Hypoxemic respiratory failure, cardiac arrest, hemopneumothorax, bronchopulmonary fistula, and pulmonary. So these are SCQs. Please. Thank you very much.